This is Zavin with On Rounds, presenting a framework for abdominal pain that supplements the traditional anatomic approach. The anatomic or quadrant-based approach to abdominal pain is very helpful. This approach considers all of the structures, starting with the skin and going all the way to the retroperitoneum that could be involved in a particular part of the abdomen. However, it is limited by two problems. First, sometimes the pain is generalized or poorly localized. Other times, the area that hurts does not actually correspond to where the actual problem is. For that reason, it is helpful to realize the two different ways in which pain from the abdominal cavity is wired, and to supplement one's approach with this understanding. So, sensory input from the abdominal cavity travels via one of two main pathways. Visceral pain is from the innervation of the actual gastrointestinal tract. It is caused by either distension or ischemia of the gut lumen. It is experienced as midline, vaguely localized, crampy pain, and it is mapped by the distribution of arterial supply to the GI tract. The celiac trunk, which supplies the embryologic foregut from the esophagus all the way to the half of the duodenum, is experienced as midline epigastric pain, as in the example of biliary colic. The superior mesenteric artery supplies the midgut from half the duodenum all the way to the transverse colon, and it is experienced as periumbilical pain, for example, from a distended appendix. Finally, the inferior mesenteric artery supplies the hindgut, and pain of the second half of the colon is experienced as pelvic pain, as in the example of colonic distension from constipation. By contrast, parietal pain is from the innervation of the peritoneum and organ capsules. It is caused by cutting or inflammation or other types of chemical irritation of those structures, and it is experienced as sharp, finely localizable, and thus often lateralizing pain. And its mapping is very much akin to the sensory innervation of the skin, meaning the area of the peritoneum or capsule that is directly involved is where pain is actually experienced. So I will now review some common abdominal syndromes to further demonstrate this dichotomy. First, appendicitis. In appendicitis, a fecalith obstructs the lumen of the appendix, and the first thing that happens is that the distal appendix distends. This causes visceral pain in the periumbilical area, midline, because the appendix is part of the embryologic midgut. Only when the appendix becomes inflamed and that inflammation starts to irritate the adjacent peritoneum does the pain lateralize to the actual location of the problem, and that pain is now peritoneal and in the right lower quadrant. In the example of biliary colic leading to cholecystitis, at first the gallstone obstructs the cystic duct, and the gallbladder, which is part of the foregut GI tract, is distended and causes visceral midline epigastric pain, not right upper quadrant pain. Only when the gallbladder then gets ischemic and inflamed and starts irritating the nearby liver capsule and peritoneum do you start having actual right upper quadrant parietal pain. Diverticulitis, while it is very analogous to appendicitis, for some reason the diverticula don't tend to obstruct and distend as much, and the pathophysiology more or less starts with actual microperforation, and for that reason the pain starts as parietal, usually left lower quadrant pain, without having a visceral midline component to begin with. The example of a perforated gastric ulcer is interesting because it's one of those causes of abdominal pain that patients can often locate to the exact second that it started, because as soon as the stomach perforates, the very acidic gastric contents spills into the peritoneum, immediately irritating that peritoneum and causing initially local parietal pain that can subsequently generalize as the acid moves around in the peritoneum. Finally, in visceral or mesenteric ischemia, if you throw a clot into the superior mesenteric artery, that is going to cause ischemia and thus visceral pain, and it's going to be experienced as a nonspecific midline, vaguely localized crampy pain in the periumbilical area in the example of SMA obstruction, or potentially in the epigastrium or in the pelvis, depending on which artery is ischemic. Finally, it is important to remember that some causes of diffuse or vaguely localized abdominal pain don't actually have underlying structural pathophysiology and instead can be thought of as having systemic or metabolic causes. These include hypercalcemia, ketoacidosis of any etiology, adrenal insufficiency, porphyria, hereditary angioedema, or any cause of serositis in the abdomen, sterile peritonitis from lupus, uremia, familiar Mediterranean fever, and so on. So to summarize, in addition to the anatomic or quadrant-based approach, recognize that abdominal pain can be either visceral from distension or ischemia of the gut lumen, or parietal from inflammation or mechanical injury to the peritoneum or the organ capsules. And these pains are experienced very differently.